Hello, Dr. Poole and EBP classmates. This is Hannah Claiborne coming to you from Nashville, Tennessee. I am presenting on psilocybin therapy on depression. I apologize for my poor videographic skills. I'm recording this on my phone because I couldn't figure out how to record it on PowerPoint. So if it's a little shaky or you can hear my dog barking, I apologize. So, introduction, therapy and pharmaceuticals have significantly impacted the lives of people who suffer from mental health issues such as addiction, anxiety, and depression. Yet, medicine still has a lot of room to grow. Could there be other treatment options available that are even better than the current standard of practice? Over the last 2 decades, psilocybin has emerged again as an effective treatment for many health issues, including addiction, dependence, depression, inflammation, chronic pain, and epilepsy. The uses of psilocybin to improve patients' quality of life are endless. However, this PowerPoint presentation and my synthesis project are only focusing on psilocybin-assisted therapy as compared to the current standard of practice for depression. Only talking about psilocybin and depression. Significance of the problem at hand. The depression is the leading cause of medical disability today. It affects 260 million people all across the globe, and approximately $210 million are spent on depression disorders. I believe that's annually. Depression symptoms include feelings of sadness, lack of energy or interest in daily activities, difficulty sleeping, low self-esteem, suicidal thoughts, forgetfulness, concentration issues, feelings of worthlessness. And another statistic for you that's very sad is an increase in suicidal rates by 35% over the last 18 years. Therefore, my PCOT question is, adults with depression ages 18 to 75, how does psilocybin-assisted therapy in comparison to the current standard of antidepressant treatment affect depression symptoms within a year's time? Since population is so short and very straightforward, it doesn't have its own slide, but we're working with 18 to 75-year-olds, and depression disorders affect 10% of the U.S. population, so quite a bit. And patients peak in their 20s and then again in their 50s. And women are 2 times more likely to develop depression than men. And then my intervention is psilocybin-assisted therapy, or you'll see psilocybin psychotherapy. And then in comparison to current standard of practice, which is antidepressants, the outcome is decrease in MDD symptoms, major depressive disorder symptoms, and then over a year's time. The intervention, as mentioned, is psilocybin and psilocybin-assisted therapy. Psilocybin dates back to the 1500s in Mexico and Central and South America. This is a natural occurring compound found in 180 species of mushrooms that have been used in religious and healing practices for a very long time. This is not new. Psilocybin causes a psychedelic or hallucinogenic effect. Psychedelic means in Greek psyche, which is mind and soul, and delos, I probably butchered that, which means to show. So therefore you are showing your mind and soul. And it was first coined by a psychiatrist, Humphrey Osmond, in 1956. Psychedelic therapies or psilocybin therapies have been rejected for some time just because of the way the word conducts a certain stereotype, if you will. But we're breaking the mold here, and we're kind of coming out from that. But it was rejected by pharmaceutical industries, social understanding, and government acceptance. But now psilocybin is now underway on its safety and benefits in treating depression and many other things, but focusing on depression here. It's divided into 2 categories of hallucinogenics. It falls under the serotonergic and the dopaminergic classes, my apologies, in which interacts with this serotonin and dopamine receptors in the brain. And of course, we know from our studies that these receptors are responsible for emotions such as mood, anxiety, aggression, and cognition, sex, learning, memory, appetite, along with other biological, neurological, and neuropsychiatric processes. So it taps into these areas of the brain, which is one reason why it works. Then our comparison is the antidepressant therapy, the medication that we use. Common antidepressant classes are MAOIs, tricyclics, and SSRIs. And then you may have heard these names before. Prozac, Zoloft, Celexa, and Lexapro are your common ones. These are effective after months of administration, daily administration for months. I just want to kind of hone in on that and make that underlined. And then they are full of negative side effects, including suicidal ideation. And then this image, I'm not sure if you could read it, but reported side effects of long-term antidepressant use that are not pleasant. Sexual problems, weight gain, reduced positive feelings, feeling dependent on the medication, and feeling emotionally numb. And these aren't great and are part of the reason why a lot of people stop taking their meds once they feel good, or they stop taking their meds because they don't feel good. Another downside to antidepressant therapy is treatment resistance is common. This is where you're just not responding to any medication, and that becomes a problem. So the next couple slides, we're going to be talking about each of the studies that I looked into as my outcome. So Swift and colleagues did a double-blind crossover RCT with 2 doses of psilocybin or a placebo given along with therapies and interviews. The psychotherapy techniques included palliative care theory, attachment theory, existential psychotherapy, mindfulness training, logotherapy, and then psychoanalytic therapy. Upon completion of this trial, those were given psilocybin reported accepting their surrounding diagnosis, dismissal of fear, reconciliation of death, inner peace, and spiritual connection, and elevation of depression. I should have started with this, that this was a group of cancer patients who were given this therapy to combat the depression and fear of the diagnosis. So once again, with the psilocybin therapy, they dismissed the fear, they reconciled death, they developed an inner peace, and the depression around this diagnosis just kind of went away, and they actually had a deeper spiritual connection. Next was Carhart-Harris. This is a big research group that I saw a lot working on psilocybin. They did an open label with 2 doses of psilocybin given 7 days apart, along with cognitive-based therapy or CBT sessions. They measured their depression symptoms on the QIDS, the Quick Inventory of Depression Symptoms. It's 16 categories around sleep, appetite, thoughts of suicide, concentration, energy level, views of self, and other things. These researchers discovered the reduction of suicide ideation, reduction of sexual dysfunction, reduction of depressive symptoms, remaining positive, these numbers positive, for 3 to 6 months. They found that psilocybin was successful in treating treatment-resistant depression as well, which is a very big deal. Continuing on, I cannot pronounce that. Al-Kashai and colleagues, they did a qualitative research on 10 participants after 2 doses of psilocybin. And one thing that was very powerful for me, most participants reported thinking clearer after psilocybin was administered. 1 participant was able to cease taking 3 antidepressant medications and sleeping pills after 2 weeks of taking psilocybin. Participants also reported mind-expanding effects, which contributed to more positive outlook on life and a deeper sense of peace and connection and appreciation of self. Davis et al., which is another big component in this research, they did a random control trial on 27 patients given 2 doses of psilocybin followed by supportive psychotherapy, and they were rated on the grid Hamilton depression, which is another scale similar to the QIDS. It's 17 categories, I believe, and they did this at baseline and again 2 more times over the course of 8 weeks during this therapy. Their results included lower suicidal ideation, lower self-reported depression, and decreased psychological distress lasting for 4 weeks. And a follow-up to this study, Guy Kassan and his team conducted a follow-up for Davis up to 12 months, and this is one of the longer studies we have dealing with these psilocybin and depression symptoms. They found similar results as Davis. Their participants scored lower on grid Hammond even up to 12 months, and that is very exciting. Doss et al. Did a 24 participant study on the grid Hammond scale as well. They were looking into depression symptoms as well as changes in MRI. They found that with psilocybin, their patients were able to concentrate and have more cognitive flexibility and ability to think about multiple concepts at the same time, lasting for about 4 weeks. Their research is similar along the lines with the others I've presented on reduction of depression symptoms. Lee et al. Performed a meta-analysis and systematic review of 5 studies testing psilocybin on participants with the diagnosis of MDD. Their study is consistent with many others, demonstrating the findings of safety, expeditedness, and effectiveness of this therapy. They did call for future researchers to find a unified dose of psilocybin to continue further studies. This is my evidence synthesis table that I wanted to present to you guys. And one thing that I thought was really powerful, that all evidence presented of all the 7 studies saw a decrease in depressive symptoms after only 2 doses of psilocybin. Each study only did 2 and saw results in after 2. After 1 especially, but definitely after 2. And then 5 studies reported lasting effects for 6 months or longer, which is amazing. My search results are here using South College Library database searching psilocybin and depressive agents. I got 161 peer-reviewed. When I knocked it down to full text, I got 117. After the exclusion criteria and inclusion criteria were applied, I received 60 journals, and then 6 I chose. Inclusion criteria included random control studies, qualitative and quantitative meta-analysis. Participant had to have a diagnosis of MDD on the DSM. Then exclusion included other psychedelics used in therapy. There are many times where the psilocybin was compared to ketamine, and that is effective as well, but that's not what I wanted to focus on, and then needed to be in the US, and we weren't working with addiction studies, and of course no duplicates. Proposed change and practice recommendations. All of the studies I found said that we need more studies comparing psilocybin directly to specific antidepressants with more placebo studies. All studies mentioned needing a larger, more diverse sample size. My primary stakeholders here are, of course, the medical professionals providing this care. We need people trained in psilocybin therapy and trusted medical professionals to do this. It's a very vulnerable place to be in as the patient. And then, of course, we need a target population. My proposed change model is the clinical scholar model. I was attracted to this model because it promotes a spirit of inquiry, which is exactly this quest with psilocybin and depression, requiring researchers to keep an open mind and the participants as well. This model encourages researchers to observe the needs of the population and staff, and in this case, depression is not being defeated by our current way of life with our antidepressants and our current standard of care. So we need to find another way. Using this model, my team will gather research, synthesize the evidence, and form pilot studies with larger sample size, placebo-controlled, qualified therapy sessions, and a solidified dose of psilocybin. So my conclusion here, depression is growing in severity. It's not stopping. And psilocybin-assisted therapy has shown to be an effective treatment to improve depressive symptoms and increase the quality of life in many studies. I will say majority of the studies reported word for word there were no adverse effects other than a headache, which that's pretty good. We only have about 12 months of a long-term study, so that's definitely needed to see if long-term what happens. So the current standard of practice, antidepressants, comes with many adverse side effects, and taking daily doses for months in comparison to psilocybin, which results are seen after 2 doses. So I think that's another big thing. Comparing psilocybin to antidepressants, researchers saw results with 2 doses rather than daily intake for months. And little to no adverse side effects, once again. So, in conclusion, depression cannot be ignored, and psilocybin studies have thus far proved to be beneficial, safe, and work more quickly than the current standard of practice in fighting depression and its symptoms, beckoning the need for further exploration. Thank you guys for listening and watching. I appreciate your time. Hopefully this isn't the last you see of this, and good luck everyone in your next class. And here are my references. Thank you.